Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Good evening. Welcome to your Direct Connection. We begin tonight with mass confusion, or is it mask confusion? Philadelphia, for example, pulling the plug on a new COVID masking order after just 1 week. Tonight, straight answers to your questions about who needs to wear a mask and when. Joining us is Dr. Nilesh Kalyanaraman, the Anne Arundel County Health Officer. Doctor, it's great to see you again. Let's start with a status report in your communities. We know the positivity numbers are creeping up a little bit in Maryland, but hospitalizations are pretty low. Is that what you're seeing?
Yes, that is. So what we're seeing is that the cases are starting to go up, and they've been doing that for a few weeks. The hospitalizations have been ticking up slowly as well, but they're still at a low level overall for the state and for the county.
This newest variant that's gone around is obviously, super contagious. Thankfully, it doesn't seem to be as deadly, but still people are dying from this.
That's right. So it is more contagious. I think what we've been through with the Omicron surge in December, January, February, between the vaccinations and the exposure, that gives us some amount of protection against this new variant, the BA2.12. But it is still dangerous. And for those folks who are not vaccinated, it's really important to get vaccinated. And to also remember that there's oral treatment available for people who do get sick and have high-risk conditions.
I do want to ask you about that, the pills that are out, and also what's happening with long COVID. But let me stay on masks for a minute. Mm-hmm. If you're going to get on an airplane these days, so it was a week ago today, a federal district judge threw out the CDC's order or authority to do the mask mandate, and it wasn't stayed for some reason, and everybody rips off their masks. In that situation, especially with nobody else wearing a mask, I'm going to wear a mask. What do you think?
Yeah, what we try to do and what the CDC is trying to do is make sure that we're all protecting each other. When we're on public transportation, including on flights, all sorts of people are coming together who don't know each other, right? And you don't know what they have and you don't know the situation. This kind of flips the responsibility onto the individuals to decide, am I at risk? Do I need to protect myself? And the fact is, you don't know what everybody else is doing. And so our general recommendation is if you're on public transportation, continue to mask. It's not going to hurt you to do so. It's going to protect you and it's going to protect others. And it's particularly important if you have any chronic health conditions or if you're older to keep up that level of protection, especially when it's spreading.
When we saw a plane load of people before, or you were on the subway or something, it was always half the people weren't wearing the mask right anyway. I mean, if you want to protect yourself, do you need a high quality mask and do you need to wear it the right way?
Yeah, you definitely want to wear a high quality mask, a KN95 mask, or at least a surgical mask, and it's got to cover your nose, mouth, and chin, right? The thing we talk about. And we know that there's some portion of people who are not wearing their mask correctly, but a lot of people are. And that's every single additional person just gives more protection to that group.
Let me remind our viewers, if you have a question for the doctor, give us a call at the number on the screen, or you can email me a question, livequestions@mpt.org. Let's start with a call from Anne Arundel County. This is Ruth. Ruth, thank you for the call. Go ahead.
Yes, I have travel planned to Edinburgh, Scotland next week on May 4th, and now I'm getting a little concerned, thinking I should cancel the trip. I would be there for 2 weeks.
Without giving us any personal information, do you feel like you're at especially high risk for any reason?
Well, I am older, and I have waited to get the 4th booster. I'm saving that for when I feel like I really need it. So my booster was in September, which feels like a long time ago.
Interesting. Thanks so much for the call. We'll get you an answer on the air. Doctor?
Yeah, a couple of things there. I would recommend going ahead to get that next booster. It's been about 7 months, it sounds like, and that's certainly more than enough time. You're not really saving the booster because there will be additional recommendations that come. As for traveling, one of the things that we look at a lot is what's the spread where you are compared to where you're going. And right now, there isn't that much additional risk in going anywhere else, given that place. It's more about what are you doing there and how are you gonna protect yourself. So I would say wear a mask on the flight, of course, and then just be mindful about when you're out and about in Scotland, about whether you want to wear a mask around in crowded areas or when you're indoors. But it's time to go ahead and do some of the things that we want to do in life.
I think that's how so many people feel about it, that they're ready to go do things. They want to be careful, don't want to be foolish about it. And that's why it's such a complex thing, depending on where you're going and what your situation in life is.
Yes, exactly. And we have additional tools that we didn't have just 6 months ago. And so it makes it easier to go forward with our plans, whether it's travel or meeting friends or whatever the case may be.
What's happening in your school system?
So what we're seeing is that the classes are full. Most kids are not wearing a mask at this point. I know that we saw a good number of kids wearing them after they came back from spring break, of course. But we're seeing some level of COVID, but not as much. It pretty much mirrors what's happening, in the surrounding communities.
What about vaccines for kids? I don't even know what the latest recommendation is, but I don't think it's kids under age 5 yet.
Yeah, so the vaccine for kids 4 and younger hasn't been approved yet, and it looks like there's another delay in terms of when that data will be ready for the FDA. So parents of younger kids are going to have to continue to hold on for a while longer.
Phone call from Howard County. This is Barbara. Barbara, thank you for calling. Go ahead.
Hi, I'm about to get my 4th booster. Are Pfizer and Moderna equally protective, or is one better than the other?
Great question. Thank you.
So that is a very good question. Generally, we're seeing that the Pfizer is slightly more effective, but Moderna is certainly a good option. What our recommendation is getting a booster. Either of those two boosters is absolutely better than not doing anything. So I wouldn't worry too much about which one, but if you do have a choice, I would suggest the Pfizer.
Don't hate me for this, but I'm waiting on the second booster. So I've had 3 doses of Moderna. I feel sufficiently inoculated at the moment. But if things were to start trending in the wrong direction, the hospitals are filling up, I would run out and get one. Otherwise, I figure at some point there'll be another wave to deal with.
There will be. I think that's the challenge, is we don't know when that's going to be. Is this what we're seeing, this increase, that wave? Is it going to come later? And that's why we generally suggest just go ahead and get that booster, because sometimes you just don't know how to time that, right? That is always our biggest issue. If we knew what was going to happen, we'd be better prepared.
Got it. Yeah, I'd like to get my booster like 2 weeks before I get exposed. That brings us to the, pardon me, the antiviral medication. And who is that recommended for? And does it change anybody's risk calculation a little bit? If somebody is higher risk and they know that this is available, if they get it quickly enough, does it make sense to maybe venture out a little bit more?
Yeah, so there's 2 oral medications. One is called Paxlovid, one is called Molnupiravir. They have slightly different age groups that they're approved for under the EUA. I think the key thing to know is that those 2 medications, they're meant to be given within 5 days of the start of symptoms, and they're meant for people who are at higher risk for severe disease. So people with chronic health conditions or immunosuppressive conditions, or people who are older. And so if you fall into that category of being either older, generally we think of that as above 50, or with any chronic health conditions at any age, if you do develop COVID, regardless of what vaccines you've gotten, please talk to your doctor or go to an urgent care center, because it's really important to start that medication sooner. And they're really effective, particularly the Paxlovid, at decreasing the chances of severe disease.
Is there any application of those for long COVID cases?
They're looking at what medications or treatments are going to help for long COVID. One of the challenges with long COVID is that it encompasses a lot of different symptoms and durations. So we know that some people have mild symptoms a month or so out, and some people have more severe symptoms that last longer. So there's a lot of research that's going into long COVID right now, but there really isn't, these medications aren't a treatment, and there really isn't a treatment yet that we have for it.
This time of year, my little sniffle reminds me that there's pollen all over the place. You should have seen my car this morning. It was just covered. And people with allergies, I mean, we sneeze, we cough this time of year, and obviously there's other symptoms that go along with COVID.
Yeah, that's right. And then we've dealt with this throughout the pandemic, which is get tested if you start to have symptoms, even if you have these seasonal allergies. We had pollen covering our dining table inside our house. What you want to do is just do that one test, make sure it isn't something else. And with the at-home test, that's a lot easier. I know than the last couple of years when we suggested that, you had to go out, get a PCR, wait for a while, right? That was a lot harder.
Let's squeeze in one more phone call. Harford County, this is Priscilla. Priscilla, go ahead.
All right. I would very much appreciate the doctor explaining why the Pfizer is a slightly better shot.
That's a great question. Let me stop you there. Doctor, I've heard the other way. I've heard people like Moderna.
It actually just has to do with the data that the CDC shared when they authorized that second booster. That was what it was based on, the data that they saw in other countries. Now, one of the limitations of the data is that it's dependent on which vaccines were available in those countries. And that's why I said getting a booster is far more important than which one.
And in terms of the at-home, the antigen test that you mentioned, pretty good availability in your county?
Yeah, we're seeing widespread availability, both for free at libraries and health department sites, and also online. People are able to buy them pretty easily now.
And they don't have to report the results, so there's a little bit of squishiness in the data.
We absolutely know the data is squishy, but that's okay. As long as people are testing and following those results, that's what we want. Dr.
Nilesh Kalyanaraman is the Anne Arundel County Health Officer. Doctor, we really appreciate your time. Thanks so much.
Thank you.
Joining us for our Your Health segment this week is Dr. Chandra Body, professor of surgery at the University of Maryland School of Medicine and a transplant surgeon at the University of Maryland Medical Center. Doctor, thank you so much for joining us. This is Donate Life Month. Let's start by just talking about the purpose of that designation.
Thank you very much for having me here. As you all know, that the April is a month of Donate Life, and we celebrate this month to respect the people who have donated and people who have been waiting for transplantation. This month is celebrated to recognize the honor and generosity of patients who have been waiting for transplantation. This month-long observation is also an opportunity to encourage more Americans to register as an organ, eye, and tissue donors.
The need for those donors is quite apparent when you look at the wait lists that you have for procedures.
Yes, as we all know that there's a urgent need for patients who are currently listed for transplantation. At this moment, currently there are about 120,000 patients who are listed for kidney transplantation or liver transplantation, out of which about 100,000 patients are listed just for kidney transplantation. When we look at the patients who die currently on a waiting list, is about 13 patients die each day while waiting on a kidney transplant list. Every month, about 3,000 patients go on a list. So if you do the statistics that every 14 minutes one patient get listed, and we are not transplanting enough patients at the same time. So patients are dying while waiting for organ. We have both ways to help these patients who are currently in need of transplantation in the form of disease donor transplantation as well as the living donor transplantation. The patients who are currently, the donors who currently get registered, if something happens to them, they become a donor, or the patients who are otherwise healthy can donate their organs to the patients who are in urgent need of transplantation.
You know, thinking about the tragedies that are represented in those large numbers of people on the waiting list, but what you get to do as a transplant surgeon is to fight that tide. You have people coming to you who are desperately ill, and if everything goes right, you're able to save their lives and put them back on the path to good health, which has to be enormously rewarding.
Absolutely. I can't emphasize enough on this sentence which you just said, that the patients, when they come, they're very sick. Particularly when we look at the liver transplant patients, they come at almost at the deathbed. Me saying this means that the patient, if they don't get a liver transplant, they die within a short period of time. And when they get transplanted, they go home. You see the difference what they make. I say the patients, when I see them back in about 2 months, you won't be able to recognize them. Their life completely transformed, and they go back to their normal routine, which they were not going. At the same time, when you look at the patients who were in need of kidney transplantation, their life is so much revolved around the dialysis that every second day they're going to dialysis. And when these patients get a kidney transplant, and it changes their lifestyle completely, that they're back to our economy, they're back to their lifestyle, they're back to their social circle, they're not depending on the dialysis. Their life expectancy goes up with the transplantation. We have enough data which suggests that the patient, if they stay on a dialysis, their life expectancy is much, much lower in comparison to the patient who received transplantation.
The reasons that some people, many people perhaps, are hesitant to put their name, far ahead of time at a young age on a donor list, maybe concerns about what might happen, maybe religious objections. How would you answer any of those concerns?
So I would like to tell everybody that anybody can be a donor. There is no contraindications to be considered as a donor. We as a physician never consider a donor if we think we're going to cause any harm to the donor. All patients who are considered for living donor, whether it's a kidney or liver, they get evaluated completely. We go through their history, physical exam, do all the laboratory work. We follow a principle, do not harm. We will not take any organ if we think there is any risk to the donor. Our foremost priority is always the donor. And the donation is encouraged by all religion. There is no religion which says that the donation cannot be done. We will evaluate the donor completely before they proceed for any living donor donation. We will go through their history, we'll go through their exam and make sure they are considered as a good donor. Sometimes we might come back and say that you're not a good donor because of health-related issues, because of a social situation, but we will evaluate you completely. There is no financial constraints on donor. Everything related with the donation surgery is covered by a different form. You should not receive any bill for what you have done, because you're already helping a different person you're already helping your loved one in the form of giving the most prestigious gift of life.
What's changed over the years in terms of the procedures, the surgical procedures, whether it's the living donor, whether it's the transplant recipient? How's it different? And I know you're increasingly using robots in the operating room.
You very well said that the technology keeps changing. We have becoming more and more smarter in the form of taking a patient care. We have much better immunosuppression medications. We have much better surgical tools by which we can make the patient go home early, return back to their life much quicker. In the past 20 years ago, we used to do the surgery with the open cut, and the patient was waiting in the hospital for staying in the hospital for 5-6 days. They're taking about 2 months to go back to routine life. So it was too much. Now we have changed from open technique to a minimally invasive technique. Means the patients who are undergoing whether it's a kidney donation or liver donation, we make small incisions by which we do the surgery. We make about 3 or 4 small 8 millimeter incisions, and we take out the kidney. We, particularly at University of Maryland, uses the most latest technology in the form of doing robotic surgery. The surgery lasts anywhere between 2 to 3 hours, and patients go home next day. So it's a very, very minimal trauma to the patients. Of course, not everybody goes home on a day one, but most of the patients go home on a day one. Most of the patients are off pain medication by the end of the first week, and they return back to their original life in about 2 weeks, as long as they're not doing a heavy duty work. But if they do heavy duty work, then they require a little bit longer period of time. So this technology definitely has a benefit for patients. Much less pain, much less incisions, cosmetically better, early recovery, early return of work, everything is much quicker than the traditional open cut surgery. We do the surgery in the form of kidney donation. We do the surgery partially in a liver donor. So we do the surgery to make patients recover much quicker. Sorry.
I was going to say, when we see the high-tech robot rolled in, we can see you at the controls, but it's not at the point where it's artificial intelligence running the thing. You're actually performing the surgery with the assistance of this robot holding the various and moving the various devices.
Absolutely, you're very right. So the robot doesn't mean that the robot is going to perform the surgery. We still control every single movement. When the patient goes to sleep, we connect the robot to the patient's body, and pretty much after that, every single movement, whatever the surgeon who's sitting on a console performs it, get mimicked in the human body. So it's essentially robot works as an extension of a human hand, but we get a 3D vision. The movements are much more finer. It's much more precise movements with the robotic technology. That's why we typically like to use the robot for this thing. We are one of the few centers in the country who perform even a kidney transplant with the robot. So that the traditional open cut surgery, where we were giving incision of about 15 to 20 centimeter, now just changed to 6 centimeter incision with the 3 and 4 ports. Typically, kidney transplant patients who are staying in a hospital for at least 4 days to anywhere up to 7 days, the patients are going home on day 2 to day 3, and they return back to much quicker. So robotic technology definitely helped them in a quicker recovery. At the same time, one of the patient population which was not considered for transplantation were obese people. Most of the kidney transplant centers in the country would decline patients whose BMI over 40 for a kidney transplantation. We are one of the few centers who would still offer them as long as we see that there is no medical contraindication, and we perform their surgery with the robotic technology. The chances of their recovery is much quicker. They have a much less wound infection. And as I mentioned, they recover much quicker in these patient populations. So there are definitely advantages of the newer technology, which again, very few centers are performing currently.
And that's something certainly that prospective living donors would be happy to hear. How difficult is it to make a match? And has that changed at all over the years, that in addition to blood type, several other factors that had to line up perfectly?
So you're very right. So we look at quite a few things when we are matching them. In a kidney transplantation, matching is a little bit more complicated. We look at the blood type as well as we look at other things. While in the liver transplantation, we just look at the blood type. There is no other thing which we look at, and there is no other matches required. Of course, when we do a living donor liver transplantation, the patient had to have a scan to make sure the anatomy is physical for the patient to donate. While on the kidney transplantation, we do the typically CT scan or MRI to make sure that the patient, again, does not have any issues with his own kidneys. At the same time, it's suitable to donate. But overall, both surgeries, we do everything what is required. And if there is not a match, we do have an exchange program. We do take participation in a national exchange program where we can tie up with a different program, and kidney can come from there and our kidney can go from there. So there are a lot more ways by which we can help the patient, even they are not perfect match.
Doctor, before we go, people have been seeing in the news the transplantation experimental so far of organs from different animals into human beings. Is that going to be the future?
Well, there is a lot of things which are unsaid, but I think that this will change the future. There are a lot more things which we are working on currently, and we will know as time will go along. As you know, we are the first center to perform a pig heart into a human, and that the surgery was successful and patient lived for more than 2 months. And I think this will be a future. More and more technological as well as genetic changes will come into play, and we should be able to reach a certain point where these organs can be used safely. And we are very close to get this thing to see in a real life. There are already kidney transplantation performed in brain dead patients, and I'm pretty hopeful that soon we will be seeing as a routine part of a procedure.
Dr. Chandra Bhatti of the University of Maryland Medical Center. Doctor, thank you very much.
Thank you very much.
And that is Direct Connection for this week. Join us every week at this time for your chance to ask the experts. Please follow us on Twitter at MPT News for updates on our future guests and topics. We're back Friday with State Circle, the latest on Maryland politics. Join us for that Friday evening at 7. And now for all of us here at MPT, thanks for watching Direct Connection and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.